We're turning now to the next session, which focuses on scaling public and faith-based collaboration to better serve local health needs. We're going to hear from governments, multilaterals, from global and regional public sector actors to hear about how they are working together and how they are exploring opportunities to scale up their work. It's my pleasure to introduce Bud, who is arranging furniture and people. Bud is yet another member of our organizing team. We are quite a number. I don't know, are we 15 maybe in the long-term organizing group? Bud Rock is the president and CEO, very important person, of Grand Avenir. Bud, the floor is yours. Thank you.
Well, thank you all for joining me here today for what is nearly the final session of our two-day event. And I'm going to admit to the fact that I had a little bit of a conflict in my own mind about this particular session, about whether it really belonged at the very beginning of our two-day event or closer to the end. And I say this because I think that we all have done an excellent job here of addressing the uniquely valuable role of faith-based healthcare facilities in our communities. I think we have focused on the imperative for it. I think we've touched on the methodologies. I think we're trying to ensure that these facilities are maintaining the acceptable standards for adequate WASH. I might argue, however, that we haven't yet explored the relative goals and the relative capacities between the faith-based hospitals and clinics and the broader national public health systems. The hope being that there is coordination and there is consistency existing between these two groups. Okay? The reality is that faith-based institutions and the relationships that exist with public health systems vary widely. They vary in scope, they vary in formality, they vary in governance, they vary in finance. But they all presumably are working toward common goals. I found it interesting that in some countries you may have faith-based facilities that are literally fully contracted and regulated as part of the national health policy services. You may have other instances where the faith-based facility is what you might call a parallel provider. They're coordinating selectively with government programs, HIV, maternal and child health, vaccination campaigns, matters of that sort. You know, when I found it curious throughout the sessions where we would speak about in Africa, for example, I heard everything from 1/3 to 2/3 of the facilities are faith-run. But what we don't always reflect on when we use those figures is that frequently those facilities are also still very closely linked with national public health agendas and agencies. In some countries like India or Pakistan or in the Philippines, there is a very close relationship between public health, between healthcare facilities and medical colleges, for example, religious hospitals and medical colleges, and public health programs, including, for example, the national health insurance systems. And yet at the same time, there are strictly retained religious governance systems. Coming from the United States, we are an obvious example of this, where faith-run health systems own a substantial share of the hospitals and clinics in the United States, and those facilities themselves are deeply embedded in the government public health systems through Medicare and Medicaid and insurance systems and related programs, and yet they are legally private institutions. So there is an expectation, there's a hope, I should say, more than anything, that public health agendas will always include the adoption of consistent, reliable standards, norms, and practices for adequate WASH and healthcare facilities. The same is expected of faith-run facilities. We go to hospitals and clinics with the expectation of proper care. Hospitals provide those services not based on religious affiliation, but on standards of care for all. I'm going to depart from the comment that I have written here to say one small thing, which is when I was young, I spent far too much time in my local community hospital, and I'm thankful for the time that I spent there. Only in the past few years, and I'm considerably older now, did I find out that that hospital was established and run at that time by Daughters of Charity. It was my community hospital, and that is true in so many communities. The idea, however, is that the common approaches amount to creating trust, creating some level of trust in care within our communities. And I'm confident that faith providers have a great deal to share and a great deal to learn from these public health sector relationships. And that's what we're going to spend a little bit of time exploring today. Our format for this will be to have a bit of an exchange and dialogue with two regional experts in this area. And then I'd like to also hear a little bit more from our two international organization representatives from WHO and UNICEF concerning their relevant program activities to this cooperative relationship that we're speaking about. I will look at my notes specifically for this because I am pleased to be joined today by colleagues Dr. Mary Ashinyo, who is a physician specialist in public health and a global health expert in epidemiology, health policy, and systems management. She has served as Ghana's national focal point on WASH and healthcare facilities, and I might say has worked with many of the organizations here today. She's a colleague and a friend. Thank you for joining us. Dr. Moy Makoka has just completed his tenure at the World Council of Churches. He is the Program Executive for Health and Healing. He holds a medical degree from the University of Malawi and Ryan, a postdoctoral training in public health microbiology from the University of North Carolina at Chapel Hill. Congratulations. He's also, by the way, previously led the Christian Health Association of Malawi. Dr. Margaret Montgomery, Maggie, is an environmental engineer by training and a technical officer of the World Health Organization, coordinating the activities related to water, sanitation, and hygiene, and is absolutely instrumental to our work on this topic. I don't know where we'd be without you, Maggie, on this. And finally, Max Sani, who serves, and I hope I am correct in this title, the Global Lead for Social and Behavioral Change at UNICEF. Max is going to speak, by the way, specifically about programs involving the Religions for Peace, a group whose representative was unable to join us today, unfortunately. Okay, so if I could just begin with Mary, I think we're picking up a bit on where we left our discussions right before lunch. What I was hoping you'd reflect on was a little bit about your experiences and what you see that we can do that might encourage or maybe ensure that the WASH efficiencies are addressed uniformly by healthcare facilities, whether they are faith-based or whether they are public-run. How do we share the strengths, and frankly, how do we overcome the challenges collectively? Mary?
Okay, thank you very much, Bud. And Maggie is smiling at me, so she's expecting me to say very great things. I think the last 2 days has been very inspirational. Please permit me to stand on the existing protocols. Yesterday, when I listened to Sister Smerili, I was really inspired. She emphasized care, which should be holistic, and that sent my mind to the biopsychosocial model. Just last year, I was thinking about Ghana's health system and health systems generally, and I thought that we needed to go back to grounding healthcare in faith. So I formed a group called Doctors for Christ Network, and I created a WhatsApp group where I go every day and I drop a memory verse. And I say what I think about the memory verse. Little did I know that I would actually be coming to Rome to talk about WASH in healthcare facilities. And today the memory verse that I dropped there is 1 Thessalonians chapter 5, verse 15, which says we should not do wrong for wrong, but we should do good and what is good for everyone. And I think in that verse, I found the principle of equity. So we've been talking about WASH, but WASH is not just for health. It's also for justice, it's for security, and it's for equity. And that, I think that is the grounding for which we have to do WASH and health generally. So on that premise, I think the advocacy is that we should provide health care, which we usually say we are providing, instead of health services, which is usually what we actually provide. And that is why WASH is very, very important. So what do we have to do to improve efficiencies across government and faith-based agencies? I have 5 points. The first one is that we need to reflect from the public side. I know Dr. Yeboah has said a lot about the CHAG side, which I'm very excited about and to build on. So the first point is that from the public side, we need to really reflect on the science of decision-making and how we allocate resources across not just the government agencies, but also the faith-based, the private sector, the quasi-government, and all healthcare providers by ownership. So that is the first one, reflecting on our decision-making on resource allocation and seeing the faith-based services as part of the national health system. That is the first one. The second one is to think about coordination and networking. So when we talk about coordination, in the case of Ghana, just like the Global Task Force for Cholera Control does, and also the Global Task Force for WASH in healthcare facilities, which I got the opportunity to serve on with Maggie and colleagues who were at WaterAid. There's a really intentional, and I think that's the word, very intentional mapping of stakeholders to say, who really do we have to include in the conversation to make sure that we are scaling WASH in healthcare facilities? And back in Ghana, we have a similar coordination mechanism. So this is not just a coordination that can be done at global level. We can learn from the coordination at the global level and come to the national level. In Ghana, we have a coordination that was coordinated by the Ministry of Water and Sanitation, which has now become part of the Ministry of Local Government, and that includes the health sector, the education sector, the local government, and a lot of non-government actors and development partners who work around WASH. And I think that the next step that we need to do is to bring that coordination to the health system. So that coordination is what will give us the opportunity. So the coordination that we have now is not just WASH in health. It's WASH in health, WASH in schools, WASH in the communities. But if we now come to ministries of health and we establish coordination systems for WASH in healthcare facilities, that means it will not only be the Ghana Health Service, for example, it will also be the Christian Health Association of Ghana, it will be the private sector, it will be the quasi-government, it will be the police health services, the military, all the agencies that provide services. So I think we can deploy the experiences we've learned from the global coordination to the national level of coordination. And then also looping ourselves into the networks. Usually I get a complaint, why are we not including CHAG into WHO work, Africa CDC, the UN system, when we are going to World Health Assembly, but Ghana has a good example. When we are going to World Health Assembly, Dr. Yeboah goes to World Health Assembly. Africa CDC, unfortunately, sometimes when funding is involved, the Ministry of Health will quickly push the funding to the Ghana Health Service because that's the leading government service delivery agency. And, the whole understanding is that, yes, we have an MOU with CHAG, but then they keep their IGF. They don't tell us what they use the money for. And so when we have funding, we also want to spend the money on our healthcare facilities. But I think that we need to come to a point where the Ministry of Health is able to say, when it comes to service delivery, the CHAG and other ownership, they are providing a good proportion of healthcare services. We used to say that Ghana Health Service provides about 80%, but that's not the case anymore. CHAG is providing, I don't want to mention a figure that would make Dr. Yeboah happy, but CHAG is providing a good proportion, and the private sector as well. So we need to really go beyond thinking about the money that CHAG gets and thinking about actually the health as a national system. How do we deploy the resources to all the agencies of the Ministry of Health that actually provide services in the country as a national health service? So we should not only be looking forward to Ministry of Health taking that decision. I think CHAG also, I know Ghana does well, but in countries where that effort is not existing, we need to encourage the faith-based system also to be proactive. There's nothing wrong with you sending an email to WHO, for example, or the Ministry of Health, for example, and say, we need some interventions in WASH, and we'll be happy if we are included in the interventions. The third one is programming and integration of data systems. And I think there's been a lot of conversation about data already. But in terms of programming, when there's donor funding, we don't talk about CHAG. We don't channel some of the, if WHO sends us funding for a program, we don't loop in CHAG necessarily at the headquarters. But somehow in Ghana, we have a unique arrangement. At the sub-national level, the CHAG facilities, they report to the regional directors of health service. So sometimes if we use the data to select the facilities, most likely some of them are CHAG facilities. But we need to have an intentional effort where the Ministry of Health says, well, WHO is bringing us this project and CHAG needs to be at the table at the national level. In terms of capacity building, when we develop guidelines on WASH in healthcare facilities, we should not just send all the printed copies to Ghana Health Service. We should distribute across private sector and also CHAG. And I think we learned that lesson during COVID. Until everybody is safe, whether you are government or you are faith-based hospital, none of us is safe. So if there are infections still in CHAG, you're not going to say because you are faith-based, you are not sending gloves there, you're not sending PPEs, you are not providing water, right? So it's the same thing. Until everyone is safe, whether in public or in faith-based, none of us is safe. And then also advocacy. We shouldn't just assume that everybody knows what we are talking about. When I joined headquarters, and I realized that people really didn't know what WASH was about. And I remember one high-level meeting where I made a presentation on WASH, and my colleague doctors came to me and said, oh, Dr. Shinyo, so all this WASH you've been talking about is actually just water and toilet and hand washing. Yeah, because it sounds like, doctors, we are just interested in writing a prescription and giving an injection, and the nurses get more interested in IPC and WASH, right? So we should take our time to demystify WASH. Let everybody understand what we're talking about. Let's make it simple for people to appreciate. Sometimes doctors run away from the conversation because they don't understand it and they don't want to show their ignorance. But when they see a doctor involved, they are more confident or more comfortable coming to ask their colleague. I think that is also one of the things that helped when we got doctors involved in the leadership of WASH in healthcare facilities. It became more friendly for people. We also, when I joined headquarters, we also introduced the National Healthcare Quality Conference and Patient Safety, which became the largest health gathering in Ghana. And we always allocated a session on WASH specifically. Every year there's a session on WASH, just to keep WASH on the agenda. And finally, the point I wanted to add as the fifth point is accountability. And this is mutual accountability. It is not only government or public sector that needs to be accountable to other stakeholders, but other stakeholders also need to be accountable to government. So if you are bringing in funding, it's not like government is going to collect your money, but at least if you do a technical briefing, let government knows what the objectives are, what you wish to achieve, and this is your budget, who is funding you. Those simple conversations actually build trust. But if you hide everything, you don't want to talk to government about funding, they become suspicious. It's not because you are hiding money, but by just the fact that you didn't talk about it, you leave questions in their mind. They get suspicious, and then they also don't want to promote your work, because when questions arise in the future, they don't know what they will tell who funded you. So I think accountability, mutual accountability, will also help to improve the working relationship between private, faith-based, and public, and all the other service delivery stakeholders. Thank you.
Mary, thank you very much, and I yield to a physician specialist to comment on the inadequacies of physicians in there. That's a tough pitch to make, I know, in the healthcare environment. I want to turn to Dr. Makoka, and I'm not going to give you the benefit of the first question I intended to ask you, because it was, we touched on this so much, and I know we want to follow up on it. But we spoke earlier today about how faiths can cooperate more effectively in communities. But you and I spoke about something that I found very interesting recently, which was, how do we engage the congregations themselves, the faith congregations, more actively in a role to help their faith community to be more proactive in the WASH area? As you pointed out in my discussion, there are many instances in which in the community, the bishop or the senior religious representative there has a great deal of responsibilities. How do we help that faith leader work with that congregation to elevate its role and engagement in the community? Am I fair to put the second question first?
No, it's okay. But I just, thank you very much. I just make maybe a few bullet points please. On the first one, which was about interfaith collaboration. My final points there were, we can't do it all alone. So this is for everyone to understand. I think if we approach collaboration and partnership from that point of view, we can't do it all alone. Now, it may be simple, it may be complicated, because there are situations where one has an excessive sense of strength, and it may be financial, it may be whatever, it may be your history, it may be, and partnership becomes a struggle, and this collaboration is forced. The other bullet point, which is really from an ecumenical point of view, is what are we doing? We're building the kingdom of God. So ecumenical collaboration becomes easier when we approach it that we are building the kingdom of God. We may be, I think there's a story about people preparing bricks or stones, and one said, yeah, I'm just cutting down stones. I'm building a cathedral, building the kingdom of God. So I think getting to a higher vantage point, it helps to rise above many local considerations that become hindrances to collaboration. And sometimes partnership is not as meaningful because we sort of deviate from some of these really critical guiding points. When it comes to working with congregations and churches, I think in my role, I worked at the Christian Health Association for some years, and then the World Council of Churches, which doesn't have any church. And so when we go around, we don't necessarily own any particular church. And as a Christian Health Association, it was an umbrella, a network. You can't claim ownership of any health facility whatsoever. Actually, those who were constructing that hospital, and some of those hospitals existed maybe 50 years before the association was created. So it has an existence of its own. And when we go to help them, to work with them, sometimes the helper is moving ahead. The owner has no idea what you're doing at their hospital. The general secretary, the moderator, the bishop, the parish priest have no clue and then you want sustainability. And it's usually not a surprise. When you leave, everything you started, it dies. Because those who are the owners, who several years before your institution existed, they built that hospital there. You left them behind. And so that kind of sustainability becomes very tricky. But working with the church has also its own challenges. And sometimes we may lack the nuances and the expertise and the social engagement and the awareness on how do we work with churches. Sometimes it becomes more difficult. So it may become like, when we go this way, the work becomes more difficult. You have more people to convince. But it is very critical for the long-term sustainability. And I jotted down some notes here. The healing ministry belongs primarily to the church. And the church, I mean the body of Christ. And only by extension does it belong to the specialized ministries, the specialized work, which we can say like healthcare workers. It's a very critical starting point, because we can't assume that because I am a doctor and we have a church hospital, therefore the healing ministry has virtually transferred from the church to the hospital. The healing ministry primarily belongs to the church, to the pews where people sing hymns, Bible study, choir. We are a specialized ministry, so we cannot completely take away health from there and become so specialized that it's very clear, like the church has subcontracted the healing ministry. So going back, promoting health and healing and awareness and all this messaging primarily in the church should be our primary concern.
You raised that, you raised an interesting point with me recently on this regard, though, and I hope I'm not misrepresenting this the way it was said. But you can have instances where, say, a Catholic run hospital has been developed in a community, established in a community. You may have a Presbyterian church where the congregation will go 100 miles away to work and assist the Presbyterian church, but not assist the Catholic church in their own community. Now, this is an interfaith exchange. This is literal when we talk about interfaith collaboration. Are we in a situation, or can we be in a situation, where congregations will literally work together in communities to ensure that the one hospital, faith-based hospital, is as successful as it possibly can be?
Yeah, I think we need a little more willingness and openness, because, as you said, we have a situation, a geographical area. You have a church owned by denomination A, and all the other churches within that neighborhood, they say, oh, that's not our hospital. If we are collecting a Sunday offering to give a special support for children, we collect that and send it 100 kilometers away, because that's where our hospital is. Yet when I'm sick, I go to this hospital. And if you are operating that hospital, you may say, oh, it's our hospital, don't come. If you want to do any health work, go where your hospital is. I think this kind of grassroots, on the ground collaboration is extremely important for ecumenical sharing of resources and political positioning of the work. And I think we need both a top-down and a bottom-up approach. We need, at the top level, verbalizing, posturing, giving positive vibes of collaboration, non-sectarianism, and working together. And also at the grassroots, we need good examples which can be shared and replicated, refined. and be shared as a good example so that maybe we can say, this is what's happening at place A. If you want to do it here, it will not be unique. It's happening elsewhere. And so that becomes sharing of good practice.
I wanted to turn for a moment. We've talked about this back and forth relationship between faith-based facilities and government facilities. In my workings recently with our friends from the Anglican Communion, it was pointed out by one of our program leaders in the Philippines that they have a very unique situation in that they had faith-run hospitals and clinics that, as they became more and more successful, they were in a position to actually turn those facilities over to the governments. And so the government took ownership and responsibility. They are still run as Anglican facilities, but they are truly government facilities in every sense of the word. I found this very interesting, so I sent a note to our colleagues in the Philippines, and we received a video from the Anglican Prime Bishop, Nestor Poltic, of the Philippines. So I'd like to just, if we could, quickly show the video, because he was gracious enough to send us a note about their collaborations with their own governments. Do we have that video?
Easter greetings from the Episcopal Church in the Philippines. 100 years ago, the Episcopal Church opened up mission work in the Philippines following what its founding Bishop Charles Hendegren referred to as the three-pronged ministry to the soul, the mind, and the body. The ministry to the body resulted in the establishment of clinics in areas where mission work was open and where medical care was limited or non-existent. 3 of these clinics were later developed into hospitals. St. Theodore's Hospital up in Sagada Mountain Province, Brent Hospital down in Zamboanga City, and St. Luke's Medical Center in Quezon City. Over the years, public and other private hospitals were established all over the country, prompting our Episcopal hospitals to focus their services to those that were not available or not provided. St. Luke's Medical Center focused on advanced medical care, while Brent Hospital expanded to include health-allied educational services. In Sagada Mountain Province, the government opted not to put up a public hospital and instead support St. Theodore's Hospital. Our medical centers, therefore, are now providing services that are complementary to what government and other private institutions are doing. The prospective partnership with international agencies to enhance water and sanitation facilities in our hospitals, specifically with St. Theodore's Hospital and Brent Hospital and colleges, is very much welcome, as the provision of adequate and safe water and sanitation is becoming a serious problem, compounded by climate change and ecological challenges. We look forward to a fruitful and productive partnership. Thank you very much, and God bless everyone. Easter greetings from the Episcopal Church in the Philippines.
That message, I think it's the classic representation when we can literally have governments at the local and national level saying, you, the faith-based hospitals, are doing precisely what needs to be done. Let us step in there and help support what you're doing and make it that much stronger. That's a partnership that I think we all aspire to. You know, when we speak about the standards and the norms and the policies that are applied to healthcare facilities, we're actually very fortunate to benefit from the fact that the entire topic received a global call to action from the United Nations Secretary General back in 2018, and that resulted in a broadly endorsed global implementation plan led by the World Health Organization and UNICEF. And I feel that we just wanted to give an opportunity for that context, that global context, to be brought into the discussion. So I invite our colleague, Maggie Montgomery from WHO, to say a few words about the global plan and its relevance in the faith-based context.
Super, thank you, Bud. And just to say, I'm feeling very inspired and very grateful for all of you and this opportunity. So I just want to thank you. I just wanted to bring a few things. I have a few documents and I don't want to take them back with me. So if anybody wants hard copies, I will give them for free. Just very quickly, the Global Framework for Action, if you haven't had a look at it, please have a look. Many of you in this room or your organizations contributed to it. World Vision, CRS, UNC, Emory. It lays out very clearly what are the targets, right? And you can say, okay, the global targets, do they really matter? Probably in the village, no, right? But at the national level, at the regional level, and certainly at the global level, these targets do matter. They're now embedded in many of the global health strategies, and 5 years ago, that wasn't the case. So they're in the IPC global framework, they're in the high-level statement of AMR, they're in the standards and work around child and maternal health, and I'll say just a few things about that because it's really exciting to see more and more studies coming out, especially around maternal sepsis and newborn infections and WASH. So please have a look at this framework. The second thing, and a colleague pointed out to me, and it was not on purpose, but God works in mysterious ways, that it looks like Mother Mary is on the cover of our latest Global Progress Report. So this is a report that came out last year, and I really want to thank, in particular, Bud, because he talked about the Secretary General's call to action, which led to a UN General Assembly resolution in 2023, which mandates further that WHO and UNICEF need to regularly monitor and report on what's happening. And that monitoring is happening in two ways. So one is we're looking at services, and if you haven't gone to the washinfo.org site, I encourage you to do so because there's even sub-national data there. And I totally appreciate and applaud the effort to go beyond numbers, but the numbers do matter, right? And we've seen, especially at the national level, when governments wake up to the situation, they can't ignore it. So have a look. The latest data is going to be coming out in July. For the first time, we have global estimates for all 5 areas: water, sanitation, hand hygiene, cleaning, and I really appreciate some of the discussions about how do we encourage and professionally support all health workers, not just the ones providing care. Have a look at that data. The other piece of data that's in here, and it's been also come up, many of these actions are around the national actions, so around the system strengthening. And that's on the country tracker, which is on the website, which hopefully you've gone to go look at because it's on your QR code. But if you go to the main page on that website, and just to be clear, that site is meant to be a collective site. We purposely did not put branding on the front because we want this issue to be something that goes beyond any one partner, any one UN agency. So that data, looking at national standards, looking at national coordination mechanisms, looking at costed finance roadmaps is all there. We've done really well on the standard side. And a part of that is, I think, because of the WASH Fit. So this is the last document I'm going to show you. We've heard it come up a lot during the discussions. And just a few things to say that we have a whole package of resources. It's all freely available on WASH Fit. So if you go, again, to that site, which is on your QR code, you'll see it in all 5 UN languages. It's now in Ukrainian as well. We also have some open access online courses on WASH Fit, which if you go to WHO Academy, these are jointly branded as well. So even though it's on the WHO site, it's done with UNICEF. We're about to launch an advanced healthcare waste course. And this course is super exciting. I've been involved in it. We have interactive tools. There's a bunch of videos because the waste issue in particular is coming up more and more. And I was happy to hear that question. So there's a whole slew of materials. And there's the basic issues, right, of segregation and how do you handle hazardous waste, but issues now around pharmaceutical waste, around mercury. So we go into a lot more detail about what you can do and what some of the emerging technologies are, especially on the treatment side. So really encourage you to have a look at that. I also just wanted to mention that on the leadership side, and again, this is driven in part by the UN General Assembly resolution, there should be an updated one coming out hopefully in the next few months that goes into much more details around some of the issues around equity, is the Global Strategic Network. Mary mentioned it as well. And this is a group of leaders from health, WASH, energy, and development who come together virtually twice a year to talk about, okay, what are the emerging trends? What do we need to do to shift mindsets and shift action at the global level and the regional and national level? The next meeting is the 7th of May. Tebaldo, I think, is not here at the moment, but we are hopeful that he can give a report back on this meeting and how we can talk more specifically about how we better engage, integrate all the work you're doing, both on the technical side, but on the leadership side, right? Because for us, it's both. You need a top-down and a bottom-up, and all of you, especially on the bottom-up side, I think have some really important lessons, engagement to share. Very quickly, okay, WHO commitments. We will continue to monitor the situation, to report through our global reporting and through our development of technical resources, and in particular, continue to engage with and change the mindsets of our health colleagues. Right? Like, this is not finished yet. We need to make sure we talk about ownership. This is a health issue, right? And in particular, especially around maternal and newborn health, we've seen a stalling of maternal mortality figures for the past 15 years. I was just looking up the data. A woman is 60 times more likely to die during childbirth in Mali as she is in Italy, right? Like, that's horrendous. It shouldn't. Those inequities are huge, and we know that improving the cleanliness of our facilities, equipping midwives and nurses with the ability to deliver babies safely is super important. On the WHO side as well, we will continue to obviously advocate government, right? And I realize in some ways it's really nice to have a safe space to talk outside government, but in order to scale, we need to increase our public investments. We know it's affordable. We've done the costing on it. We know it's a matter of prioritizing, and we know that the cost of inaction is high, as we've heard, but the cost of investing is actually not that great. So government will continue to be our main focal point, and certainly welcome the opportunity to encourage our country offices and, as a result, the ministers of health to make sure the faith-based organizations are part of those national task force, are sharing the data, are engaged in the activities. This is not meant to be an exclusive thing. We need everybody. Just lastly, about what's next, and I was really happy to read on the commitments page, and thank you all for all of you for submitting those, that many of them align with what we've already kind of signaled as well globally. Like, one, we have to reach the most vulnerable, right? It's just shocking. We still have so many people who are unserved, especially in sub-Saharan Africa. We need scalable, affordable models, right? So pilots are great, innovation is great, but if we can't afford to scale it, it doesn't make sense. And we also really appreciate the idea of incremental improvements. We can't go from 0 to 100 overnight, but if we can get to 40 and maybe to 60, we could probably get there. Also, we have to look at these emerging threats. We have issues around spread of AMR from sanitation systems. We have increase, for example, of Legionella and waterborne disease within our water systems. So we can't just meet the basics, right? We need, as we're making upgrades, as we're putting in new technologies, think about these other emerging threats, alongside, obviously, climate change, and now, unfortunately, conflict. And some of those resilient issues for conflict and for climate overlap a lot. We have to embed in government systems, and we've talked a lot about that. We still only have something like 18% of countries who actively monitor WASH and healthcare facilities as part of health systems. Like, that has to change. We have to keep looking at emergencies, and I was really pleased to see so many people here who are working in emergency situations, right? We cannot ignore those situations, but it means we have to do things maybe differently, not as thoroughly, and we need to make sure they're part of the emergency health plans. And then the last thing is on the investments. And I've been really encouraged to hear some discussion about, yes, of course, we need to try to generate more resources, but how do we make better use of the resources that are already there? How do we engage governments, whether it's lifting taxes, whether it's getting paid to actually deliver services because that government can't reach it? I think are all important issues and financial mechanisms that we need to look for. Of course, we will still advocate to our donors and to our partners that they need to invest, but I think we need to start looking at these other avenues as well. Maybe just the last thing to say that another thing I took away from this was joy. And I hope that we all continue to address this issue with joy, because I think that's really important, especially as it links to the dignity and care. So thank you.
Maggie, thanks very much. And I want to highlight two particular aspects about this relationship that we have here with the World Health Organization, strengthening as it is even at this moment. Two things. One is that when you are making the case for the importance of standards and norms and protocols, et cetera, you can say with confidence that this is something that draws out of global action and is something that has been constructed in a careful way through the World Health Organization. So we do indeed have the standards and the norms and the protocols that we expect should exist in all of these facilities, faith-based and otherwise. And the other aspect is that when you, and we have heard this throughout the 2 days, when you hear people saying, well, but how do we reach the leadership? How do we really get to them? Well, it's the WHO that's speaking to the ministers of health and the public health systems, and we should utilize that. We should bring to the WHO the best examples that we have of the activities that the faith community is doing, and put them to work. So we'll see what we can do on that. Max, turning to you as our last speaker, you have a unique initiative in your partnership with Religions for Peace and the African Council of Religious Leaders. I'm looking forward to you telling us a little bit more about it. Again, I apologize that our RFP representative was unable to make it, but I know you will address the issue adequately and fully. Thank you, Max. Go ahead.
Thank you so much, Bud, and good afternoon. So my name is Max. I'm not a WASH expert nor a health expert, and I'm social and behavior change expert, so a social scientist, right? And it was actually very joyful to hear that there is a lot of expertise in the room on behavior change. Many of you refer to actually SBC, community engagement, participatory approaches during your presentation and when you were sharing your experiences. And that was first time that I don't have to advocate for that. Actually, the faith institutions are the most experts on doing behavior change since centuries. Usually I have to do it with colleagues like Maggie or colleagues like our WASH chiefs in UNICEF or our health chiefs. So that was very rewarding. Just to say that it was also great to hear from Maggie that actually this is a joint initiative, obviously at global level. Lindsay, our colleagues, she's our WASH in healthcare facility specialist, could not attend, but I'm very grateful that she expanded the invitation to also bring our team to support this initiative globally. And UNICEF, beyond being part of these global commitments, defining standards, is also an implementer. So we have actually supported over 34,000 healthcare facilities with WASH services improvements in the last few years, many in collaboration with your organization, obviously, through partnership on the ground. But my intervention will be how we can actually leverage also our expertise on social and behavior change and community engagement to further scale what we do, not only at the FLCD side, but at the community side. And bringing more, again, increased motivation of actors, increasing participation, support from our communities on WASH-related behaviors. So first of all, maybe let's demystify what is SBC to those that maybe have not worked on our field. Well, we are trying to understand actually why people do what they do. That's our main focus, right? We try to understand why people behave in a certain way, and then we have to try to remove those barriers, because actually people don't necessarily need more information all the time. Sometimes it's an issue of information and knowledge, but in many instances, actually the barriers are either on the supply side, or maybe it's an issue of norms. If I do something, I will be sanctioned by the community, for example, or it might be an issue of lack of prioritization, and I don't have anybody role modeling those behaviors in my community, so I don't feel that I have to also act upon that. So based on our, again, programming across multiple areas, we have learned that if we put in place participatory approaches, we have an increased chance to actually produce social and behavior change. If we are doing positive role modeling, again, bringing the leaders to your faith leaders and speaking for these type of issues is going to actually create automatically some imitation and some actually modeling and increase the chances to actually produce change. We also need to develop different ways of triggering change. So community-led total sanitation is a proven solution that has been implemented not only at community level, but also in the institutions, right? And so we have that approach. Let's use it. Let's share it across all your network. And you can also become CLTS, let's say, partners, implementing partners, when UNICEF is pushing it for that with governments, with local governments, and so on. And also we are trying to replicate this idea of, again, social modeling and certification of community open defecation free at family level. So we also came up with a concept of model families in some countries where you are promoting a basket of behavior, including hygiene and sanitation related behaviors, and then there is a certification process to actually, again, elevating and give status to the families that are achieving that. And they're doing it basically with their own resources in many instances, right? And finally, in terms of principle, one that I think we haven't mentioned these 2 days is that the data that we are collecting at community level or at facility level, they don't have only to speak to decision makers, to managers of the health facilities, but need to speak back to the communities. If we have saved lives because we invested on hygiene, on WASH at health facility level, let's use those data to create a dialogue with the communities. That's very powerful, actually, and it has been a key principle that we are trying to promote. Finally, now moving more into what we are doing in our institution and in partnership with the Legion for Peace. Since 2018, we actually realized that actually our country offices were already working with multiple faith partners. But it was a bit isolated and sometimes was a bit utilitaristic, if I may say so. We have a polio campaign, we need your support. Please do the promotion of the polio campaign. And that's it. And then we continue to work separately. So we try to come up with an initiative that could be interfaith, multi-partner, and it's called Faith for Positive Change for Children, Families and Communities. And since then, we actually work a lot on producing new guides, for example, for behavior change during COVID, so promoting behavioral behaviors that were key to prevent COVID, on immunization demand, on child marriage, female genital mutilation, and other topics. And now we would like to actually expand to WASH and healthcare facilities. So that's one, producing guidelines for faith actors, but co-developed, not UNICEF coming in with from our side, from our offices, producing a guide and give it to you. On the contrary, let's co-design it, having the theologians reviewing the passages, ensuring that actually it speaks a little bit to what Ruth actually described this morning. So that's one. The other one, we also thought that it was important to develop a participatory approach for capacity building. And so we came up with a mind and heart dialogue capacity building package and a manual. Again, I heard the bishop actually mentioning about mind and heart this morning. So I think it was a very reasoning actually with what we have done. And this manual is actually available for you. It's agnostic. It can be used on any topic. But the idea is also to create faith literacy among the development actors as well. So not only us bringing, let's say, the science to faith actors, but also try to promote faith literacy among UNICEF staff, government staff, so that we can work more in equal terms. Again, it's a big endeavor, so I'm not saying that we have solved all the problems, but we're really trying to work together on this. And finally, also, we produce several, let's say, engagement that we call them faith and science conferences or faith and culture conferences on important topics, including obviously on COVAX, when we introduced COVAX a few years ago, but also on child marriage and FGM. And we organize these engagements with our faith partners. And we want to replicate that also on WASH and healthcare facility in Nairobi, probably in Q3, and we're going to actually expand, I think, the organization committee, inviting, for example, colleagues from ACHAP. I mentioned to Kata if she would be keen to support us with her team, and similarly other partners that might be interested, so that we can actually do this together, because you actually have more expertise than us on this particular field. So we are actually bringing more the SBC and community engagement science, but we will rely on you for all the work that has been done on Washington Healthcare Facility. Finally, also, we have a lot of tools and guidance on SBC, on social and behavior change, that is actually available to any partner. We have a global guidance site, sbcguidance.org. I will share it through the organizer. That is actually available to any partner. We have a podcast. It's called ABC of SBC, so the basics of SBC, and we would like to also to offer the opportunity to create one podcast episode on the role of faith actors in Washington Healthcare Facility, and I got permission from Lindsay to invest a little bit of the small resources that we have to do that. And finally, again, it could be nice also to produce a faith guide for this particular topic with all of you. So these are actually our commitments to bring Faith for Positive Change for Children initiative closer to these important goals that all of you and all of us have. Thank you.
Thank you very much, Max. One thing that has always struck me as I'm traveling around and I'm meeting and talking with others about the issues that we are trying to tackle and the sheer scope of what is required in these institutions is the number of times when item number one, the first thing that's referenced is, well, we've got to deal with behavior change. We've got to deal with changes of mindset. We've got to put people in the framework. And what you've heard from our speakers today is that we have some basic principles with which to work. We have some program directions, and we have opportunities to engage not only within the healthcare facility itself, but in different ways within the community, in the congregations, for example, to help that drive them toward this notion that they can have a more effective means of achieving adequate wash in their healthcare facilities and become their own advocates in the community. So I really applaud the aspects of behavioral and social change that have been addressed so carefully. I'm embarrassed to say to John that I'm sliding 5 minutes, just 5 minutes behind my schedule, but I'm doing that only because I was invited by our leaders here to allow for a few minutes of questions for those who may have questions. I appreciate the fact that, as I say, I'm just about near the last session of the day, but let's allow for a few questions. I think we have one over here.
Thank you so much. So much to take in. I don't know if there's a question as much as an invitation for dialogue. One of the emergent threats that I really think is necessary to call out, especially when relate to governments, and I'm thinking of Peru specifically, so I'll stay in my lane, is the threat of the private sector. So the mining companies are doing quite a bit of harm, and I look through frameworks and I don't find it sort of called out. So it's just an invitation to think about that. Governments don't follow their own water standards, leading to corruption because the mining sector is feeding the GDP. So it's just a good sort of room for dialogue and growth as we think of the future. Thank you.
A very interesting comment. And the other point I would just add to that is the fact that we all recognize within this room that as much as we talk about the importance of health within the public sector and the role of the Ministry of Health, we do realize that ministries of health are not always the strongest ministry within governments, and that we actually need to help them make their own case in many instances. And so often when you're presenting something that sounds like it's about dealing with infectious disease or dealing with some particular health aspect, if the economic aspect of it, if the community impact, if cultural implications can be drawn in, that in turn engage other ministries, you're making a stronger case. Let's help the health ministries be able to do their jobs as well. Other questions?
Yes, good afternoon. My name is Maya, and I work actually for the Social Justice and Ecology Secretariat of the Curia of the Society of Jesus just here. I think I'm the youngest of this room, and I'm sorry if my reflection is not as relevant as it could be. Recently, I attended to the first meeting of the platform for divestment in mining, and I think regarding the fact that today we talk a lot about investment, I was wondering in which way we could relate the work you do with this platform, which is acting most especially in the Global South, because mining uses a lot of water, especially in this region, because of the necessity of armed conflicts, data centers, digital development, also energy transition. And so I think there is a big deal about that. And this platform was raised by the the network, Church and Mining, Red Iglesias y Minería, which is a big network working about the fact to reorient the investment of the church. And I think as faith-based organization, we have a big deal to work closely with church, because when people who are out of this organization think about faith-based organization, they see the church. And I think if we want to influence, advocate towards government, we have firstly to get a good image. Church has to give a good image as an example. And so firstly, maybe with this platform, we target to reorient investment of the church. We could maybe create bridge with what you do, your work, so we could reorient the investment of the church toward WASH. Maybe it's already the case, I don't know. I'm a beginner in this sector, but maybe it could be interesting to make the bridge, and that's all.
Okay, thank you very much. I think you are right. And then I'll tie your question with the previous speaker. Ghana is a perfect example of where mining is actually causing water security issues. And in Ghana, we call it galamsey. That is the local terminology for mining that is not approved and which is causing a lot of environmental problems. And galamsey is also a political issue, because you need to solve that problem. You need to think about the livelihood of people. People are engaged in galamsey because that is the only means by which they feed their families. So you can't really stop galamsey without social intervention programs for people. And I think that the church has a unique opportunity to influence. And it comes back to what opportunities does the church have with communities. The community has trust with the church. So from the healthcare facility level, for example, in Ghana, we had a program called the Community Scorecard, where the communities come together. There are 8 questions on a checklist they use to assess their hospitals. They do this every quarter. And they have to do this in the absence of the healthcare worker, because we don't want, we acknowledge the power dynamics between the healthcare worker and the community. So we don't want a situation where you assess a facility and score them low, and then when you come to hospital, they say, okay, you scored us low the last time. There's power dynamics there. So the community do the assessment in the absence of the healthcare workers, and then they use the results, the gaps that they find, to draw an action plan. And it is their responsibility to make sure the action plan is implemented with the hospital. So this is not IGF from the hospital or Ministry of Health funding or donor funding. This is the communities themselves mobilizing resources. And through the community scorecard, they have built incinerators, they've done boreholes and provided water into healthcare facilities. So there's really a unique opportunity for churches and communities. Churches are also good with fundraising, so communities can actually bring some resources to make sure there's WASH in healthcare facilities. And I think we undermine the fact that communities actually have resources, and they actually want to help to build the hospitals, meet the WASH standards, if only we are able to give them the platform to do so. And so we can extend that concept from the healthcare facility also to WASH in the community. And I think that it is one of the opportunities that the church should explore. And since Dr. Yeboah is here, I think going to Ghana, maybe the church will be the solution to the galamsey problem. Thank you.
Thank you very much, Mary. Very interesting from the perspective of the public health sector side. I'd like to talk about this for 30, 40 more minutes, if you all agree, but unfortunately, I have this hard taskmaster next to me here, so we're going to have to stop it there. That's why we have corridor discussions. So thank you all for your time in this.
Thank you so much, Bardon. Thank you to all the panelists. I agree, Camille, that was an extremely rich session. And I hope that you will make the resources, and Maggie, I'm looking at you, particularly those documents that you've mentioned here. Make sure that those resources are available to our team to place on the platform, on the information platform. So we're going to move now to our final